Hi, I'm Dr. Rudy Cashman. We have a wonderful program here tonight. We're going to be speaking about a very common problem in our practice of neurosurgery and neurology on headaches. I have with us this evening Dr. Atiya Khan, a neurologist, a specialist in headaches and in sleep. Of course, I see a lot of headaches also. Of course, I'm a neurosurgeon. I, at the moment, have a wellness center at Lutheran Hospital. And my major interest, besides my neurosurgical practice, really is aspects of the mind and the body. So I formed the Mind-Body Index, which you see on the screen up there, in which I have listed illnesses that are caused by the mind, by stress. And headaches is prominent on this list. Headaches cause from stress. About 70% of the headaches that we look at are from stress, but many more serious headaches from migraine, for example. And I have with us this evening Dr. Khan, who's an expert in migraine and every other type of headache. Although some of the headaches, obviously, I do tumors and aneurysms, different things, which I treat. So we're going to have a wonderful little discussion here this evening about the different types of headaches and how to treat them. And with that, Dr. Khan, why don't you tell us a little bit about migraine headaches?
Well, thank you, Dr. Cashman. When you think about headaches and how common and prevalent they are, I just want to show you some statistics. There are currently at least 28 million migraine sufferers in the United States who are aged 12 years and older. When we look at headaches as represented by migraines, females tend to outnumber males by 3 to 1. So 21 million females in the United States have migraines, and this is probably an underestimate. When does migraine peak? Between the ages of 25 and 55 years. In terms of how common, 1 in 4 households has at least one person who has migraines.
Wow, that's common.
So extremely common. You know, people, in terms of diseases, migraine actually is more common than diabetes and asthma combined.
Wow. Yeah.
In terms of impact to the individual, think about it. If you have headache, well, definitely you're suffering because you have physical pain and you cannot be yourself. It also affects your social functioning. You cannot be your optimal at work. You cannot be your optimal at home. You may miss work. Your quality of work is impacted. It can lead to psychosocial issues. It can affect your marriage. It can affect activities that you want to do with your children.
I've noticed in my neurosurgical practice, even I see a lot of headache problems from stress, for example, every day. And very, very interesting how common these conditions are.
Extremely. When we think of headaches, not every headache is migraines, but migraines are very, very common. And I like to think of headaches as primary headache conditions, and that would include conditions like migraines or a very common condition which is called tension type headache, where patients will present with pain in their neck, a kind of band around their head, and just headache that occurs very, very often. You get this condition which is called chronic daily headaches, where patients will present that they're having headaches at least 15 days out of 30 in the month.
Wow, I mean, that's really could be disabling.
Extremely disabling.
Yeah.
And then conditions which is called cluster headache, where patients would have headaches which occur in attacks or clusters, may occur a few days of the month, or may occur consecutively many days for weeks and then not happen for a year or so.
Do they take up the whole head or one side of the head, cluster headaches?
Cluster headache tend to be unilateral, and I have a slide about this later on.
I see. So somewhat similar to migraine.
Somewhat similar to migraine, but interestingly, it's more common in men. And one finding that you will see is patient will say they have tearing of the eye on that side or runny nose associated with it.
That's interesting. I've seen it in the past. Is it true? I mean, I've heard cluster headaches usually are a lot shorter, like hours instead of days, like a migraine might be.
That's correct. Usually it'll be like 45 minutes to 90 minutes, and typically then they'll stop. But the pain is so intense. A person who is getting it repeatedly would get terribly anxious because they know it's coming. they know that once they start in the attack, they
Yeah.
might have recurrent headaches.
Yeah, they've told me on occasion it's piercing. Is that severe?
Extremely severe.
Yeah. Yeah.
Actually, all headaches can be extremely severe. Even migraine headaches can be so intense and extremely disabling that the patient
Yeah.
is very fearful and anxious. They cannot
Perfectly
function.
understandable. I bet they get depressed. Now, is it difficult to distinguish a cluster headache from a migraine? I mean, if it's unilateral, to me as a neurosurgeon, I would find a little confusion here. How about yourself? Can you clearly tell which is which?
I think the history is the key.
Uh-huh.
When you have a patient who has a classic migraine, and I'll be talking about that later,
Yeah.
that will help you distinguish from cluster, which will happen repeatedly, days after days, and then they may have had these type of attacks before. So history is the key.
Yeah.
The other category of headache is secondary headache, and in your neurosurgical practice, you will be seeing a lot of secondary headaches. And actually, I would like you to talk about some of the conditions that you see presenting in your clinic with the headaches.
Yeah, this is a very interesting question, a very important question. Is the thing that a neurosurgeon always is concerned about is ruptured aneurysms, where we have a little berry coming off a blood vessel that has very weak walls. I would say they're thinking today that 3 to 4% of the population walks around with an aneurysm in their head. They don't have the normal walls of a normal arterial wall. It's like the inner tube of an old tire sticking out. You know, very dangerous situation. And when do they rupture? That's really the problem. The majority of patients, for example, would have maybe a frontal headache followed by an occipital, back of the head headache. But the majority would say it's the worst headache they ever had. If that's the statement, I think then you need to be worked up, be sure that's not a ruptured aneurysm. Also, if it would have happened, say, during intercourse or when you're lifting something or coughing or sneezing, that again increases the possibility of this being a ruptured aneurysm. There is such an entity, though, called climax headache, where people get it during intercourse, and it's not a ruptured aneurysm. But you have to be very careful of distinguishing the two conditions. Because if you miss a ruptured aneurysm, because it ruptured once and you survive it, actually it's so serious, 1/3 of the people die at home, 1/3 are paralyzed, and 1/3 come to the hospital in pretty good shape with a headache, neck ache, vomiting, and we can do something about it, either operate on them, but now we do a lot of them endovascular with coils. A lot of them can be coiled today. But the diagnosis is the trick. Not to run from one emergency room, they don't make diagnosis, and you go to the next, watch out. When I see that, I always think if the patient comes the second time with a headache in emergency the same day, watch out that they didn't have a subarachnoid hemorrhage from a ruptured aneurysm. It's a very serious condition. It's not that common, especially common, though, in young people. But again, they can occur in 70s and 80s also, ruptured aneurysms. Then we also have patients with high blood pressure. If you have high blood pressure, it's not well controlled. You can have an intracerebral hemorrhage, a big old clot right in the head, no ruptured aneurysm. What they have shown, though, on autopsies, that even the patients with hypertension will develop very tiny aneurysms on the blood vessels that cannot be seen on angiography. They're so small. You have to magnify them to about 3 or 4 with magnifying glass, and you can see them. And they have a certain distribution in the head in hypertensive people. So hypertension is very important to control it. When I was at DC General as a resident, I saw a lot of uncontrolled hypertension in the population because they're eating the wrong food, and especially certain ethnic groups. And they are very prone to have these hemorrhages. They occur deep in the brain, a lot of them, and many patients right away are paralyzed, and they happen to be on the left side. They lose their speech, and they're paralyzed. Very serious condition. I see a lot today. Blood pressures are better controlled, so I don't see as much. When I was at DC General in Georgetown, I saw one a day.
And certainly patients whose blood pressure is not controlled, we see this very often. Even though they haven't bled, they'll present to the emergency room with a very severe headache, and their blood pressure is out of control. So the hypertension per se can produce a severe headache.
Absolutely. Thank you, Dr. Kahn. I mean, hypertension is a common presenter of headache problems. Occasionally we see an abnormal connection between artery and vein, arteriovenous malformation. They present as a headache. That's the main vascular problems. People even with an ischemic stroke, lack of blood supply, sometimes will present as a headache, interestingly enough. No ruptured aneurysm, but they have an ischemia, just like they have ischemia of the heart, the ischemia of the brain, sometimes causes headaches. Very, very interesting. What about non-vascular disorders that cause headaches? brain tumors, how does that present? A lot of brain tumors, you have no headaches at all. But a persistent headache, say in a 50-year-old, if you're past 50 years of age and you're starting to have headaches, never had them, watch out for a brain tumor. Or the development of numbness that's progressing, or the accompanied by the headache, you have to think of brain tumors. They can be localized, they can be all over, but a lot of tumors present with very few cerebral symptoms. And raised intracranial pressure can present as a headache. We see that in what's called pseudo-tumor cerebri, seen mainly in females, many overweight, and they start having headaches all the time. And you look in your eyes and you see the pressure is up in the brain. So that's a cause of it.
And I certainly see that in my teenage patients. One of the common associations is with teenagers and patients who tend to be overweight. They tend to have pseudotumor cerebri. And the term pseudotumor implies that they're behaving like they have a tumor because their pressure in the brain is raised, but they don't actually have a tumor. So if you do an MRI, it will be completely normal. And the way we will confirm the diagnosis is by doing a spinal tap and measuring the pressure in the spinal fluid. And if the pressure is raised, then that confirms the diagnosis of pseudotumor cerebri. Now, patients say, okay, so I don't have a tumor, so I have a headache. Is it dangerous to me? It can be dangerous, particularly to your vision. The patient may not realize that it's having an impact, and what happens initially is that they'll start losing their peripheral vision, and their blind spot starts increasing. So much so that patients may not realize that they are actually developing tunnel vision because of the raised pressure.
Yeah. Thank you, Dr. Khan. A very interesting condition, a very serious condition. Not extremely common, but is seen more in overweight females at a young age.
Yes.
Including teenagers.
And another association is with sleep apnea.
Yeah.
I have seen children who had pseudotumor cerebri whose primary cause was sleep apnea. When that got treated with tonsillectomy, their headache disappeared and their pseudotumor cerebri disappeared.
It's very, very interesting. And Dr. Khan is an expert in sleep apnea. We made a DVD together on that, a very interesting subject, which many of us really have not been educated enough about. It's a very important subject, especially if you're overweight. You have to make sure it's a very serious condition. I like to ask you about temporal arteritis. Tell me a little bit, because that's a vascular thing. Tell me a little bit about temporal arteritis, a condition we see mainly in the elderly, but it can be very life-threatening.
Yes, and this is, if an elderly person presents to the clinic and they have a headache, which may be unilateral typically, it could be due to the temporal artery inflammation. Sometimes one can palpate and feel the artery, which feels like a cord, or other times you may not feel it.
Yeah, you can even see it, can't you? You can see it really standing out.
Yes, one can, especially in men who are bald. It would be easy to see.
Thank God.
Again, here the concern is visual loss, because there is an association of temporal arteritis with vision loss. And the neurosurgeons, of course, help us make the diagnosis because you do a biopsy for us. And if we see inflammation, and we also do blood work to see if there's evidence of raised sedimentation rate, which is a reflection of inflammation. Now, the important thing is it can be treated. Patients are treated with steroids, but the diagnosis needs to be confirmed. It needs to be thought of. And then it is a treatable condition.
And that's really a problem, that sometimes it's sort of passed on. You have an elderly person have a headache, you don't get too excited, it wasn't a sudden onset. This can lead to blindness, so very important to think of it, the diagnosis. But again, the tender artery, that it stands out, a sedimentation rate, a blood test is way up, and you can make a diagnosis, and the steroids are very
is the key.
important. I saw a headache patient the other day, came in with a little bit of a temperature, had an earache for 3 days, and sure enough, if he didn't have a mastoiditis and meningitis, and was leaking spinal fluid out of his ear.
Oh my.
Yeah, it had eroded the membrane that covers your brain, and there was a little bit of air in the head because of the hole in the membrane that covers your brain. So a little bit of air, spinal fluid leaking out, temperature on 2, then I did a spinal tap, and sure enough, there was evidence of meningitis in his spinal tap. So even an ear infection can cause meningitis, and really he presented as a headache, and he's in the hospital today getting better, but he's still got a pretty good headache. And it's the inflammation of the membranes that cover your brain, they have nerves in them. So they can cause pain. And especially in teenagers, suddenly start having headaches as a rash. Watch out, could be meningitis.
Definitely.
Very serious.
I would say that's one of the life-threatening conditions which present with headaches. And if a patient is there and looks unwell, looks sick, has new onset headache, which is very dramatic, meningitis has to be thought of and has to be ruled out. The earlier you get to the hospital, the earlier you get the spinal tap, the earlier your diagnosis is confirmed, and you start on antibiotics, the better your outcome. Now, there are certain viral conditions that can present with headaches, and one of them is herpes, which can present as encephalitis, which again is treatable. If you don't catch it early and treat it, the outcome is extremely poor. Other infectious conditions, which I'm sure you see a lot of and you help us by doing surgery, is brain abscess. And this may be because the patient had infection which spread from the blood into the brain, or it can be from an area around the brain. You had an infection in your ear like your patient. Instead of getting meningitis, that patient could have got a brain abscess, or it could be a sinusitis that has gone on to a brain abscess.
Yeah, I've seen many brain abscesses over the years, and some have been quite interesting. I had one not too many years ago. It was a gentleman who was from South America having a terrible headache, and it was actually a number of years ago before we even had CT and MRI scanning, and we determined there was a mass in the back of his head. So I sat him up and operated on him, and as I opened the membrane over the brain, these things jumped out right at me that were like ping pong balls, and the brain, which had been very tense, all of a sudden was very relaxed. Spinal fluid ran out. Those little ping pong balls ran to the floor, and there was a kind of coccus infection, which you get from animal feces, and especially from South America. And the brain started pulsating, and I said, the case is over. And he was cured.
Right.
And it was a very interesting case. But I'll see brain abscesses, any part of the brain, in patients, especially like a cat bite or a cat scratch or something like that.
And dental infections.
Oh,
so
dental. Thank you for mentioning that. Very common.
Right.
So taking care of your teeth is very important.
Very critical,
Yeah,
because
yeah.
infection from the gums and from the
Yeah.
teeth can spread through the bloodstream
Yeah.
into the brain. The other condition is when you have an infection in your heart, carditis, that can send off septic emboli into your brain and seed there and present with brain abscess.
Yeah.
I saw a very sad woman who in the end ended up dying. She had severe carditis and had brain abscess. They couldn't operate on her brain because her heart condition was so bad.
Was so severe. An
Right.
interesting one applying to teenagers that may be watching. I've seen brain abscesses from piercing the tongue. Very vascular. Very vascular the tongue is, and so many bacteria in there. They enter the bloodstream and go to the brain. I have seen it, and I've seen it more than once. So piercing potentially is an infectious condition.
Oh,
It can send
absolutely.
abscesses in the body anywhere, included. Can get hooked on your heart valve and destroy your heart. Can get hooked into the brain. It's just not a light thing to do. You're taking a chance when you do.
I mean, same
do
with IV
piercings.
drug abuse.
Absolutely.
I mean,
you
if
see it
you-
with from drug abuse, not uncommon. In AIDS, of course, I've seen abscesses of the brain many times from toxoplasmosis, for example, that I'll see in the brain from AIDS. And
Yeah. Well, thank you for sharing your experience with all the conditions which usually present as emergencies, and if not diagnosed appropriately or not treated appropriately, definitely can be life-threatening and be fatal in many patients. I want to shift gear a little bit and talk about migraines, because migraines are so common. And just to share with you some of the common misperceptions and hopefully clarify for your audience how it can be managed. The one thing I want to emphasize is that migraine is a genetic tendency. So it's not necessary that you should have a family history, but it's not uncommon. When I have a patient in the clinic and I want to get a history, they will tell me, oh, my mom had headaches when she was young, or my aunt has severe headaches, or she has headaches where she has to go lie down in a room. So a family history, especially in female relatives, is very common. The other aspect I want to emphasize is that it is a neurological condition. It's not psychogenic. It doesn't exist in your mind. Certainly, psychogenic factors can exacerbate it. So with your Mind and Body Institute, if you see patients who have stress, relieving their stress can definitely help their headaches. But again, it is a chemical abnormality. There is involvement of blood vessels. There's changes in blood flow during a migraine. There's changes in metabolism. There are certain chemicals that are very important, especially serotonin. And then other chemicals called prostaglandins that mediate pain. When people look at what happens at a biochemical level, certainly there's lots of abnormal chemistry going on. When you look at what's going on, there is degree of inflammation, and that's why anti-inflammatory help.
Have some value. You know, I was reading about getting ready for this discussion with you, and it was kind of interesting. You know how they talk about vasospasm being the cause of the vessels in the scalp dilate and the head they constrict, but in the end, this book I was reading, the doctor said it really leads back to inside the brain, that the chemistry in the brain really started this. What do you think? Is that right?
I think it's absolutely right. When you think about which cranial nerves, it's the trigeminal nerve that supplies the face. And the trigeminal nerve, as you know, has 3 branches. Sometimes people get confused because your trigeminal nerve, which supplies the sinuses, can cause pain in the sinus area. And people think, well, you know, it's my sinus that's involved. Well, not really. In the end, the trigeminal nerve goes to the brain, and it's the brain.
Yeah.
It is.
And affects the, I mean, it has branches to the thalamus, it has to the membrane that covers your brain.
Right.
It really is all over the place. While we're on the subject, not to get off of migraine for a second, I see a lot of people came and tell me I have a sinus headache. I say my experience, that's 80% of the time incorrect.
You're absolutely right.
If you're draining pus out your nose, it's your sinuses.
Sure.
But others, a lot of times it's stress or migraines. Would you agree with that?
I totally agree with it. I think a lot of time people think they have sinusitis and they've done rounds of antibiotics. And then they come to my clinic and in the end they do have migraines. And the treatment for migraine will take care of their sinusitis.
It's very, very interesting. Something to keep in mind.
Well, absolutely.
And you got to be a little careful because if they were to start operating on your sinuses, you better be sure that that's a sinus problem.
Exactly.
I see that.
Yes. I want to talk a little bit about the phases of migraines, and patients who have migraines know this very well. There's some symptoms that come on even before you have your headache, and I would call that your pre-headache phase, and you can have premonitory symptoms. And patients who get headaches, they know they're going to get it because they feel tired, they feel irritable, they can't focus on what they're doing, their muscles are aching. Even before the headache comes on, they don't like bright light, they don't like loud sounds. And for patients who are experienced, they know that they're going to get a migraine. And the other symptom that happens is what's called an aura. Typically, an aura is about an hour before people get a headache, and usually will last about an hour. Aura usually tends to be visual, and there are all kinds of beautiful descriptions about what people experience during a migraine. I've had patients tell me that if they stare at something, if they stare at the mirror, they can't see their face. They can see all around, but they can't see their face.
Wow.
And they also tell, very common is scintillating lights. So what we term as scintillating scotomas. Shimmeries is another way, yes. People see patterns. They see bright light in the periphery. And even little children, sometimes if they can talk and describe, they will describe beautifully for you what they're experiencing as an aura.
They must think they're in heaven. See all these
not if they have
No,
not if they've experienced headaches, because they know their hell is coming. So it could be heaven or it could be hell, right? The next phase is the headache phase, and the severity of headache is very variable in different people. Some people may just have a mild, dull headache. The classic migraine is half your head hurting, throbbing. It may not be consistently the same side. Sometimes it's the left side, sometimes the right side. Typically in the temples or in the frontal area. Very often they'll describe this as a throbbing pain. Patient often experience nausea. They may actually vomit when they have a headache. They tend to be light and sound sensitive.
Yeah, they're not draining from their nose or like in a cluster headache.
No.
I
Typically,
see. That's one of the different. Yeah.
Yes. They are just, they're feeling sick. They don't want to be around people. They just want to pull the blinds down. They want to go lie down. It's just terrible.
Could you look at somebody, and when if you know they have migraines, could you look at them and tell that person's having a migraine?
Oh, when I walk into a hospital room or I go see
Yeah.
a patient, you
Yeah.
know, the blinds are down, the TV's off, they have their covers on their head. They just don't want to talk to you. They are uncomfortable. I mean, they're nice people, but they are just, they don't
Yeah.
want to be social at that time. You can tell they are
I see.
suffering.
Yeah. I had a nurse with it, and I could always tell when it was beginning.
Right.
Yeah.
And then you would think, okay, so the headache has come, but even in the post-headache phase, this can happen for a few days afterwards. They feel tired, irritable, they have poor appetite. They just ache all over. They're just not themselves. So it becomes really important because you might have a headache which may last anywhere from a few hours to, it can last up to 72 hours. And then you're left with this post-headache phase. This is very disabling. You know, they're out of function.
How can you work like that? You can't really work.
It's
can you?
very difficult.
Yeah.
You know, how can you
Yeah.
be a good mom? How can you be a
Yeah.
good teacher?
Yeah. You get 2 or 3 kids at home, and you have this, and husband's working. How can you do it?
It's very
It has
difficult.
to be very, extremely difficult.
Right. And so this is the usual story that we will get. I like patients to maintain a headache diary where they can jot down how frequently they get headaches. One thing I do see that in women, they tend to get headaches more around their periods. About 60% of women will tell you that it's either a few days before their periods or during the week of their menses when the headaches peaks, and is clearly related to the levels of estrogen and progesterone. And it's interesting that pre-puberty, boys and girls have an equal number of headaches
Yeah.
in terms of migraines, and post-puberty, girls clearly outnumber boys.
They take over the field at that point.
Absolutely.
So it must be hormonally related. in some
Absolutely,
aspect.
there
Yeah.
is no question about it, and
Yeah.
as you will recall, as you know, 3
Yeah.
to 1,
Yeah.
females to males.
Yeah.
There are certain migraine variants which can be very scary for people, and I'm just going to mention 2. One is basilar migraine, and the other one is hemiplegic migraine. In hemiplegic migraine, the patient will show up and they will have half their body paralyzed or weak, or they may have paresthesias, and it's very scary because
Of
here's
course. They think they're having a stroke.
they think they're having a stroke, and they are so relieved when they figure out.
Yeah. How long does it last normally like that?
Usually they'll get better within a day.
Okay.
You know, if you do an MRI, their imaging
Yeah.
will be normal. But you can imagine how nervous they would be. I have some patients who experienced this on 2 or 3 occasions, and they don't ever want to go through that again. They would rather take a medication to prevent that from ever happening.
I could perfectly understand.
There's also a variant where a person can have blindness. Either half their visual field can go off, or they can be completely blind.
Wow.
And again,
You've seen cases where they're
I've seen
totally blind?
totally-
Cannot see light? Nothing?
they totally blind. And then their
Jeez.
vision comes back. Again, it's a big relief, but it's very scary when
Yeah.
it happens.
Takes a day or so?
Usually shorter, but
Yeah.
they can be profoundly dizzy. They
Yeah.
can have poor balance. So they really can look like they're having a stroke.
Yeah. What about basilar? Obviously referring to the base of the brain. What are the symptoms in those patients?
Dizziness, poor balance, slurred speech.
Mm-hmm.
So the common symptoms that you would expect with a brainstem stroke
Yeah.
is
Yeah.
what you would see with visual problems.
Yeah.
So
The cranial nerves, movement of the face, movement of the nerves supplying the throat not working right.
So just as,
Yeah.
you know, they really don't, they look very unwell. It's scary.
Yeah.
And for a physician,
Yeah.
it's scary because you think you're dealing with a person who's having an acute stroke.
Yeah.
The other thing is with migraines, they may happen infrequently, what we refer to as acute migraine. It can vary from just 1 a month or 1 every few months to several times a month. But it can also transform to what we would call a chronic migraine situation where they get very frequent headaches. And when patients get this, they know they will be disabled, they know they will not be able to function, it starts impacting them in other areas. Their sleep starts getting affected, they start getting terribly anxious, they're depressed because they just cannot be normal.
Affects their social life.
Absolutely.
Yeah. Do some people have migraines every week?
Definitely. I see patients who have very frequent headaches, and there are drugs we can give to prevent that from happening. And so one thing, if you have headaches, I encourage patients to keep a diary. Even before you have your first appointment, just use a kitchen calendar or use a diary and write down how frequently you have headaches. What brought it on? Is it really related to your periods? It just helps the physician when you look at that chart month after month or week after week to figure out, could this be a migraine situation? Could this be a cluster situation? Could this be something more ominous, like a brain tumor? It started and it's gone on.
I got to think that has to be critical for diagnosis.
Absolutely.
Because headaches, the diagnosis is really the history, isn't it? I mean, it's the history.
Absolutely.
How to begin, when it started, what aggravates it, what makes it better. It's all in the history. So recording that, extremely helpful.
Right. We had discussed cluster headaches before, and I just wanted to emphasize that, again, it's a condition in which patients have clusters of headaches, and when we talk about clusters, it's related to time. So occurring over several days in a month or in a year. Usually the duration is shorter than a typical migraine, will last 45 minutes to 90 minutes. It's associated with the tearing of the eyes, what we refer to as lacrimation or nasal congestion. It's usually in one location. So in those attacks, behind one eye or around one eye. Unlike migraines, this tends to be more common in men.
Very interesting.
Yes.
What about patients with, say, migraine headaches? I realize the pain of it, if you have it all the time, will make you very anxious. But can anxiety be a cause of it?
I think that it's so closely linked.
Yeah, it's hard
that
to tell.
It's really a chicken or egg situation.
Yeah.
Is the migraine leading to your stress and anxiety, or is your stress and anxiety leading to your migraine?
Yeah.
I think either way, if you can break the cycle, if you stop the headaches, your stress and anxiety would get better. And I think if you can in any way decrease your stress and learn to deal with stress, then your migraines would get better.
Would get better. So stress management is part of treating migraine.
Key.
It is key. Thank you.
It is key. I want to talk about triggers of migraines, and patients who have migraines will tell me this. I mentioned hormones as being an important factor. Definitely, perimenstrual migraine is a reflection of fluctuation in estrogen and progesterone levels. Stress, can't emphasize this enough. Patients who have some deadline coming up, patients having some marital issue, some family issue, job issue, stress will trigger your headaches. Certain chemicals, whether the chemicals are in food, but I hear this very often, oh, I can't stand perfumes. Please don't wear a perfume around me because if I smell something strong, I'm going to get a migraine that day.
Very interesting.
For a small subset, food items, MSG, for a very small percentage, and I think they're very unfortunate, the chocolates.
I was going to ask you about that.
I mean,
My favorite appetite suppressor
is chocolate.
Just a tiny bit.
Well.
Seems to knock my appetite off. And remember what I said, a tiny bit. And so that can set it off. Huh?
Well, but the thing is, I see this in clinic. Patients want to know, well, should I go on a special diet? Should I take out additives? Should I take out certain dyes?
Yeah.
I think this is for a very small percentage of patients, not for the vast majority. So if every time you have chocolate, you have a headache, okay, the chocolate may be playing a role. If every time you have a certain type of cheese and then you have a headache, certainly that could be playing a role. But again, don't go crazy going on elimination diet because for the vast majority, it's not going to be important. Now, I get patients who will tell me, doctor, when the weather changes, I'll get a migraine. And here's the thing with the sinusitis. Because people think, weather change, or it must be sinus pressure. Weather change can actually trigger migraines.
Does the rain cause a headache?
For some people, it does.
Well, I'm thinking Fort Wayne, we have a lot of headaches right now. 30-day headache.
Absolutely. And then the last point I want to emphasize the importance of sleep. Certainly, migraine can disrupt your sleep, but if you don't sleep properly, you are more likely to get headaches. And being a sleep physician, I see a lot of patients with sleep apnea or patients who have poor sleep hygiene, and I just can't emphasize enough how important it is to get enough sleep, get good quality sleep, because sleep and headaches are tightly interlinked.
You know, I can't but help emphasize that ever since we did that program together on sleep.
Yes.
You know, you made me read this book of Dr. Demond. Twice I read the thing, and I tell you, it helped me in my patients because a good night's sleep is just helps so many conditions. If you look at my mind-body index, those illnesses on there, they're all better if you have a good night's sleep. You just wake up more optimistic, you're whistling a tune instead of sleeping for hours like I do many times. You're a totally different person. And sleep is a really good way to reduce stress in your life. And you have to work at it and to get educated from Dr. Khan how it's done. To be honest with you, since we did the DVD, I sleep an extra 2 hours a day.
Oh, excellent.
Because you know, I turn the lights out, I don't keep the TV on. I read a little bit before I go to bed because reading causes secretion of certain chemicals, and bingo, man, I'm out.
And
yeah.
I bet you're more productive after your brain is rested.
Exactly. I get up and I always write chapter in one of my books in the morning, but even asleep an hour later, I get it much more efficient.
And patients with sleep apnea, that's one key. They'll tell me, oh, doctor, I have a headache. When is your headache? I have it in the morning, and it gets better as the day goes on. Well, when you have sleep apnea, not only do you not breathe in oxygen, you're not breathing out carbon dioxide. And as you know, carbon dioxide is a vasodilator. So waking up with a pounding headache is a hint you might have sleep apnea.
You know, that's right. If your husband or wife snores and stop breathing during the night, sleep apnea is a diagnosis. And much more common, of course, people overweight because this is very soft musculature up here. And if you're overweight, that compresses the pharynx, and you can't you're gasping for air. And a very important thing to get worked up on if that's what you have the problem. I've had people with sleep apnea who've had memory loss and transient strokes.
Their dementia got improved once they sleep apnea?
Absolutely. I had a patient fell asleep at work like this, half hour every day, was going to almost lose her job, and was getting numb on one side of the body. I think she was kinking off her arteries, you know what I mean? And then having neck pain, and one of the surgeons even operated her. Hell, if your neck was like that for a half hour, don't you think you'd have a neck pain?
Yeah.
So sleep apnea, a very important something to be aware of. To avoid some very serious problems. I'm so happy you're an expert at it.
I'd be happy to help your patients if anybody has concerns.
I actually sent them to your office. That specific case went to your office.
I want to talk about migraines in children because parents are often surprised, oh, I didn't know this could be migraine. They present somewhat differently than how adults would present. If a child can't even speak, say a toddler, very often what the symptom they would have is just dizziness, and that's considered a migraine variant. The toddler may be playing around and suddenly will freeze, appear fearful. They have an acute sensation of vertigo, and they may run and want to hug mom, and then after a few minutes they're fine. When I get that story and the child looks otherwise normal, the physical examination is normal. If I do an MRI, it's normal, and there's a family history of migraines, that is a migraine variant.
Isn't that interesting?
The other population of children I see is patients who have what we call abdominal migraine. So they have no headaches, they will present periodically with abdominal pain, nausea, vomiting. They may have seen a gastroenterologist, they may have had some allergy testing done, and may have been treated for irritable bowel syndrome.
Well,
and in the end, they end up having a migraine variant. An entity that I have seen occasionally is what's called a confusional migraine. And typically, the patient will present, it may be triggered by mild trauma or without trauma, and patient would have episodes of being very confused, not recognizing family, acting out of it, and then gets better. And it's not necessary that during that time they would have a headache. So there are variants in children that one has to be aware of that are actually migraine related.
Interesting. It could easily be missed.
Absolutely.
Yeah. Are they more common in stressful families?
Oh,
yeah,
definitely.
Same as adults.
Definitely.
Yeah.
You know, of course, sometimes I'll see headaches and the kid doesn't want to go to school, and the pediatrician or everyone labels that as school avoidance. Oh, they're
Well,
complaining of headache because they don't want to go.
I think we've heard that story before. I have a headache. We'll stop right there.
Dr. Cashman, why don't
Yeah.
you tell me, if you see a patient with headache, when would you do an imaging?
Well, I think it's a very good question. For example, that headache we talked about earlier for the ruptured aneurysm, sudden onset of headache followed by a neck pain, I would run off a CT scan every time to see if I see some blood. If I don't see blood, I do a spinal tap. If we talked about the brain tumors, how do they present as a seizure with a headache? I definitely would get a contrast study. I think every person that has a new headache, and I don't know exactly why they had the headache, I would get a contrast study. To this stage where you can't get around it, you're going to miss things. You're going to absolutely miss things. There could have been sometimes benign brain tumors, for example, can get to be the size of a grapefruit before the people have symptoms.
Right.
Because the brain accommodates and pushes the brain over, and they come in there, and the guy's got a mass in his head like that. And as I've seen in the past, especially in the children sometimes, where everybody thought the child had a migraine, and that's understandable, perfectly understandable. Many years of practice, I've seen it, and then they get a scan 5 years later. Believe me, I've seen it, and this happens to us doctors too. And you get a scan, that's a tumor.
The brain tumor.
And
yes.
you say to yourself, why didn't I get a scan? That's been the doctor feels that way, and sometimes the families feel that way. Because you scan everything walking. That doesn't mean you got to get 10 MRIs in a year. You know what I mean? I'm just saying, if it's a new condition, I think with a headache problem, I would get a scan almost on every one, but not repeatedly necessarily.
No.
But I think it's quite important. Of course, if you have an abnormal neurologic examination, they're paralyzed or numb on one side or the other, they have double vision. For Pete's sake, you need a scan. They have a seizure, you need a scan. And if these are accompanied by headaches, you need a scan every time. And I think if you're treating a long-term migraine type patient, for 20 years, and you get a scan, 20 years ago, I suggest, every few years, get a scan, because they can develop tumors, and people with migraines more commonly have strokes and different other conditions that are worthwhile to learn about, and all of a sudden they have memory loss and things like that. You could
I think
demonstrate
you have a
it.
good point there,
Yeah.
that if there's a change in a patient who has headache, so there's a change in severity, or there's a change in frequency, or something is different about this headache.
Yeah, okay.
Patients will tell you, I have headaches all the time, but doc, this headache is different. I will get a scan then.
Listening to the patient is the most important thing.
History is everything.
Yeah, the history and the patient will lead you to the diagnosis, and I think that's very important today.
I just put up some of the testing that we do in headaches, and as Dr. Cashman had mentioned, getting a CAT scan which will show us blood, whether it's in the subdural space or a ruptured aneurysm, can be very helpful. In a patient who has head injury and has a headache, again doing a CAT scan is very helpful, because it will also show fractures or air in the head, like you mentioned in your patient.
Exactly.
An MRI may be more sensitive for looking for things like brain tumors. CT angiography, or an angiography which is done in a conventional way, where they put a catheter in the groin, would help look for things like aneurysms. We will do lumbar puncture in several situations. I had mentioned pseudotumor cerebri, where we want to measure the pressure. Anytime one suspects infection, whether it's meningitis or encephalitis, doing a lumbar puncture to look at the spinal fluid, to see if there's bacteria there, to see if there's inflammation there, or in ruptured aneurysm to see if there's blood there, is critical.
While you're on lumbar puncture, I'd like to mention too, if you've had a lumbar puncture and you go home and you get up and you have a headache, it's usually a little spinal fluid leak into the muscle called a spinal headache. Very common. After myelograms and spinal taps, you see that. I didn't want to pass without
right. And most of the
that.
time, you don't need treatment for post-spinal tap headaches. Just lying flat, taking anti-inflammatory, and that's one condition where I would recommend drinking caffeine. Helps with post-spinal tap headache. But if you're not getting better, you can get what's called a blood patch. And they take the patient's blood and inject it in the spinal fluid, and that helps dramatically. Typically, we won't do extensive blood work for headaches, but depending on the situation, I may think, for example, I mentioned checking the sedimentation rate in temporal arteritis. or other conditions in which I think the headache is a reflection of a inflammatory condition in the body, a vasculitis, lupus, then I may do extensive blood work. Typically, an EEG or electroencephalogram is not indicated. However, there are patients who have migraines and they may have epilepsy. These two conditions tend to exist together more often. And so a patient who has a seizure coming from their occipital lobe, they may have symptoms which look like migraines. They can have visual aura. They may see patterns. They may have headaches. They may have nausea, vomiting. More common in children to have occipital epilepsy. But in those conditions where I suspect the patient may have a seizure disorder, I may do an EEG. Usually for your typical migraine patient, none of these things are indicated.
That wouldn't be of any value.
No.
That kind of points to that they have some seizures, that the origin of migraines really is somewhere in the brain, isn't it?
Absolutely.
It really helps point the way there's a physiological change going on.
Absolutely.
Yeah.
What you mentioned, what was it you said? It's all in the brain, or it leads to the brain?
Yeah, yeah.
Right.
Yeah.
Now, since I am interested in sleep, I want to emphasize that a patient who has headaches and has migraines, they should practice good sleep hygiene. Keep a regular schedule, and if you suspect you have sleep apnea, you snore, wake up with a headache, then discuss this with your physician, and they may consider doing a sleep study.
I think sleep apnea is undiagnosed to an unbelievable nature. Now that I'm so sensitive about that, you've educated me about it, that I see it in my practice of neurosurgery, you know, brains and spines. I think I picked up a couple of cases in the last 2 weeks where it was totally missed for many years.
And I'm sure at your Mind and Body Institute you are emphasizing.
Yes, absolutely, because we have weight reduction classes there big time, and very cheap actually, $99 for 12 lectures. I mean, there's a deal for you. And we've had many people where their sleep apnea cleared up. I mean, some people with sleep apnea, their heart even stops. They have to almost resuscitate them, and you know, some don't wake up. It's a very serious condition. I told you about the patient who had memory loss.
Yes.
And they thought they had dementia. They thought they had Alzheimer's disease, and all it was sleep apnea. When you treat the patient, that all clears up. A marvelous result.
Should we talk about headache treatments?
Yes, please.
Typically, if patients have headaches once in a while, they may take an over-the-counter medication, and the common ones I see patients taking is either Tylenol or Motrin, ibuprofen, naproxen, and if it takes care of the headache, that's fine. If your headache is infrequent, that's fine.
What about a patient who comes in and you clearly get migraines, you know, and you're the first one to make the diagnosis? How do you treat that patient?
How do I treat that patient? Depends on how frequent it is. If they come and tell me, and all they want to know is, doctor, do I have something serious? Is this a brain tumor? Do you have an aneurysm? Am I going to die? And once I make the diagnosis of migraines, they're satisfied. Their treatment is working. They get one headache every 2 months. They take ibuprofen. They're fine. That's it. I don't need to do anything more.
Okay.
However, if patients have very frequent headaches, and I see this more commonly than I would like to admit, they start using over-the-counter medications. It's almost like abuse, and they're taking pills several times a
20
day.
Advils a day or something.
Oh, it's terrible. And they're having the side effects of those medications. It's what we
Which
term
can be serious.
a rebound analgesic headache. It's almost like a drug dependency situation.
Wow.
And in those patients, then one would like to get them off the headaches and get rid of the rebound analgesic component. In those patients, once the rebound headache is gone, the headache frequency would decrease. And if a patient is having such frequent headache or such severe headache, they probably need some preventative treatment. Something they would take every day to prevent themselves from getting a headache. So the way I approach it with my patients is there are 2 ways of treating headaches. One is an abortive treatment. When you have a headache, we'll give you something to get rid of your headache. And medications like triptans or medications like ergot can help you.
And you take them by mouth or as a suppository or
Some people
injection?
are so nauseous that they need an injection. They can take it up their nose, so intranasal administration. Most of the time, either swallowing it or putting it under their tongue is helpful.
Okay, it would be an ergotamine.
triptan.
Triptan.
And the names you might hear is Imitrex or Maxalt, and those are trade names.
Okay.
Sumatriptan is, so those are very migraine-specific medications. Some patients are so nauseous that they need some medication to help them with their nausea. And so that I would consider an abortive treatment. Sometimes patients are so ill, they have such severe pain that they come to the emergency room and they actually need narcotics.
Okay.
But if you do get such frequent headaches, then you want to get them on a regime that they stop having this frequent headache.
You're right.
And the way we do that is by putting them on prevention. So preventative medications, there are several one can use. Categories include beta blockers, which propranolol would be a common one. Tricyclic antidepressants. You know, patients will say, what, my doctor put me an antidepressant, am I depressed? Does the doctor think I'm depressed? They're not depressed, but these medications in small dosage will help you with migraine prevention. Very often we'll use seizure medications.
They increase your serotonin in your body, is that the main effect?
That's the main effect of the antidepressants. And anti-seizure medications stabilize the neurons. We use calcium channel blocker, verapamil is very commonly used, again, to prevent you from getting a migraine. Preventative medications obviously have to be taken every day, otherwise they're not going to work. You can't just pop a pill when you have a headache.
Gotcha.
You've got to take it every day.
Yeah. Do you put them on stress management too, if you can?
Absolutely. And I want you actually to, if you can talk about this in terms of how a patient can learn to deal with their stress.
Oh, thank you very much. I mean, we have the Mind-Body Institute, and stress is one of the things that I deal with, because stress is the cause of what these mind-body diseases that I have listed up there, from irritable bowel to headaches, to chronic back pain, to skin rashes, everything that stress can do, and the treatments that we have available. We teach people meditation, for example. Meditation brings you into the present moment, not a tsunami of the past or the storm of the future. It brings you in the present moment through breathing techniques. Sometimes we teach them a mantra, repeating the same word all the time to quiet your mind, and have instructors at the Mind-Body Institute that teach you that, teach you deep breathing techniques. I think at the beginning of a headache, for example, I think would close my eyes, take about 20 deep breaths, and maybe visualize walking down the beach or something pleasant. You might be able to abort the headache. Also, my website, cashformindbody.com, and then if you hit the stress icon, I have a lot of things there for stress, 20 prescriptions for stress reduction, which I put together, which are quite effective, from meditation to exercise to breathing techniques. Many patients use those, are very effective. Also, I've got a little music in there, India singing a song, a waterfall to relax your mind. And underneath that, I have someone meditating. It's about 2 or 3 minutes. It's worth going through. It's not religion. This is to quiet your mind. And then some icons come across the bottom. You hit those, and those are like walks through the park, swimming with the animals. Every day they're different. I got them over YouTube. It's just great. If you're not relaxed after going through that site, I don't know what you're going to do. So that's part of prevention. And we have yoga at the Mind-Body Institute, simple and complex, and Tai Chi and Qigong. These are all exercise to quiet your mind. We even have dancing and yoga, for example, everything to promote relaxation. This helps prevent mind-body diseases, especially headaches. Massaging is very good, highly recommended. And massage beats a pain impulse to the brain. It's faster than a pain impulse. So massaging even the scalp is very effective. You know, I go get a haircut and massage my scalp. I'll be honest with you, it's very relaxing.
Oh, in India, where I'm from originally, massage is so important.
You know, they do it so much more in Korea and India, and they have shops everywhere. We need to bring that to this country. Instead of injections and narcotics, just the mind-body techniques, a good massage, some meditation, breathing techniques can cure 50% of the problems you got. And we need to be part of American culture.
Yoga and massage, I can't emphasize that.
I totally believe in acupuncture. We have a couple of people in town that do that. Can be effective for headaches. They put these tiny little needles in there, it doesn't hurt. And acupuncture is effective. And biofeedback, where they hook you to a computer, and mind-body techniques through breathing techniques and visualization techniques can teach you how to get rid of your headache and lower your blood pressure. These are very effective things that underutilized. Many pain problems, headaches that we see, too many narcotics. I see so much drug addiction. But sometimes for a few times, you got to use it.
I think for a few
yeah.
times it's very appropriate.
Yeah.
The problem is
Yeah.
medications have side effects.
Yeah, exactly.
I can't see any
Yeah.
side effect of massage.
You got it. You got it, Alexis. I love a massage. It's a rejuvenation. And we don't use it enough. We should have, I mean, regular, you know, we should have more massage people in storefronts and stuff. Go in there, $25, you get a nice massage for an hour. We all could use that. I don't see enough of it. I don't see it. Big cities you see it, but you don't see it much around here. And it's a very interesting subject, much better than addictive medications for a chronic long-term problem.
And maybe not just in isolation, but in adjunct with medication.
Yes.
So we put you
Yeah.
on some medication for prevention,
Yeah.
but then
Yeah.
look at what triggers your headache. If it is stress, look at stress reduction. And doing both,
Right.
they
Yeah.
complement each other. So
Right.
medications and stress reduction, and you may have a much better situation.
Much better result. And stress is not a mental disease. We all got stress. Hell, I got stress.
Oh, yeah.
And you know, we all do.
I have
And-
3 kids. I
yeah.
have stress.
Yeah, exactly. I tell you, don't forget about music. Don't forget about music. I find I can have a very hard, stressful day, surgery, this, that, and the other things that was going right because I treat very serious problems, accidents. As soon as I get in my car, I have my music loaded down, not somebody else's music. I don't listen to that radio. There's nothing but people trying to irritate you on the radio. And I turn on my music. I tell you, I could count to 10. And I'm in there conducting the orchestra, singing along with the music. It's a different day. It's a different day. And it's like that. So don't forget about music. I think it's a very effective way. I play music in the operating room. Sometimes I have the anesthesiologist and nurses say to me, you know, I'm doing a brain tumor all day, and you think it'd be quite stressful. Turn to me and say, we didn't realize we were at work. That's what music does. Mm-hmm. It doesn't. That's what music does. Very,
Although I'm thinking that depending on the age of the patient,
Yeah.
the different generation would have
Yeah.
different music.
Absolutely. For example, in elderly people, I have a lot of the recordings of Andre Rieu, R-A-I-E-U. You can follow him across the world. He took classical music and made it fun. And I have, matter of fact, I know him, so I have an album of him. Whenever I see an elderly person, I ask them if they watch him. They do. I always bring into the room whatever problem they got is quickly forgotten. It's relaxing.
Before we end, Dr. Cashman, I just
Yeah.
want to mention one thing. Patient want to know, can migraine lead to stroke? And I want to emphasize that typically we don't see strokes in young females. The incidence is very low. But in a young woman, if she has complicated migraines or migraine with aura, and she smokes and is on the pill, she is at higher risk for stroke.
Interesting.
So if you have migraines, I would recommend you avoid smoking.
Yeah, could you repeat that once more? Be sure we get that straight.
Okay, so young people, young women typically don't get strokes.
Okay.
Your risk of stroke goes up dramatically if you're on the pill for birth control and you smoke. So if you have complicated migraines or migraines with aura, you might want to discuss with your physician what contraception you should use, and definitely avoid smoking.
Very interesting. I want to make sure we all, that's how important that is. And I saw, unfortunately, a lady from Asia recently, very young, who had a brainstem stroke and had just started a contraceptive medication. And within a week, she had it. It was very serious. They put her in the nursing home. So it's very important to know the complications of medicines. You know,
Right.
that you could be taken. But again, birth control is important.
And avoid smoking.
Yeah.
I would like to sum up by bringing this up that really migraines is a biopsychosocial phenomena. There are biological factors, there are psychological factors like stress, and there are social factors. And if you have migraines, you should work on all aspects to have the best outcome.
Thank you very much for a very interesting discussion.
Thank you.
And we've got a few seconds left, so I'll mention to you about trauma. You know, I treat head injuries all the time. And many of these patients after major head injuries will have headaches for many years afterwards. And I think it's injury to the membranes that cover the brain and through the scalp, and very common. So, but then again, if you've had an injury and you have headaches, it should be scanned right away. You may have a chronic blood clot.